Hi, welcome to the case review. I am Dr. Keshava R, Director Cardiology, Fortis Hospital, Cunningham Road. I welcome you all for our third in the case series for a discussion today. Today we are going to have a 75-year-old male who is a diabetic and oral antihypertensive and hypertensive. He presented to us with chest pain of 3 days, typical retrosternal pain, no sweating, no radiation and no dyspnea. Clinically, pulse and BP were normal and his heart sounds were normal. And with this he was admitted, and because he came in the middle of the night, 75-year-old with the 2 risk factor, we said okay, let us admit him, and this was his ECG. If you see this ECG, if you see that he got slight sinus tachycardia, but otherwise there were no STT changes. His troponin T was normal and troponin T was borderline elevated, but he was otherwise comfortable. But since he was admitted in the middle of the night, we repeated another ECG after 6 hours. That ECG also showed that there was sinus tachycardia, there was no significant STT changes, and clinically he was otherwise normal, and echocardiogram was normal, which was also normal. And day 2 he continued to have chest pain, and troponin T, first one was 104, second one was after 6 hours was 55, which was a downward trend. So saying that there was no acute ischemic insult based on the ECG. Echo was normal, we didn't find any regional wall motion abnormality. Since ECG did not show any significant STT changes, we observed him for one more day. Day 3 his ECG, as I shown you, ECG did not reveal any STT changes. It was significantly normal with no STT changes. Troponin was trending downwards, and with this ECG we kept him in the hospital because he continued ongoing chest pain. And that day 3, this was his ECG. If you see the ECG, it shows a global ST elevation. ST elevation in you can see clearly in V2, V3, V4, V5 and V6. We can see the STT changes, and if you can see the ST elevation in lead 2 and AVF also, you can see the ST elevation. The most important thing is to realize that the AVR, it shows a ST depression and a T wave inversion with a slight elevation of PR segment. So there is a global ST elevation in all the leads with ST depression in AVR with a PR segment elevation in V1, PR segment elevation in AVR. Now on day 4 we find that all his ECG had reverted to normal with minor ST depression and a T wave inversion. So this day 3 ECG is a significant ECG suggestive of a acute pericarditis, and here you see that we are going to discuss the differential diagnosis in this patient. So this is a patient with a diagnosis of acute pericarditis. What is acute pericarditis? Pericarditis is inflammation of the pericardium following a viral infection or a tuberculosis infection, and it will cause a chest pain which is typically retrosternal, pleuritic versus on lying down flat, but increases on bending forwards, has associated tachycardia and mild dyspnea. And there is a gradually you see that normally there is 30 to 50 ml of pericardial fluid, and this pericardial fluid in acute pericarditis can start increasing. As I told you, the first echo was normal, didn't show any effusion. We will see what happened to this patient later. There may, and the most important thing is widespread ST segment elevation. Changes occurs due to involvement of the underlying pericardium, that is what you call a myopericarditis. Now, how to recognize pericarditis is the widespread concave ST elevation and a PR segment depression throughout most of the limb leads in 1, 2, 3 and AVL, AVF and in precardial leads. Reciprocal ST depression and PR elevation is seen in AVR plus or minus in V1. Sinus tachycardia is also common in acute pericarditis due to pain and due to pericardial effusion. So in acute pericarditis, what you see is a ST elevation with concavity upwards and a PR segment depression in most of the leads, and ST depression you see in AVR along with PR segment elevation. So, this is how it looks like in V5. V5 you can see that there is ST elevation of around 1 millimeter, concavity upwards, and there is a PR segment depression. What you will see in AVR is a ST depression and a PR elevation. There is a reciprocal changes. So, there is 4 stages of pericarditis. There is no uniform time frame, but grossly it is like this. Stage 1, there is a widespread ST elevation and PR depression with reciprocal changes in AVR. Most of the time in first 1 to 2 weeks, this is in stage 1. Stage 2 is normalization of ST segment and generalized T wave flattening, which can happen in 1 to 3 weeks. This is what we saw in the 4th ECG. Stage 3 is a flattened T wave becomes inverted, which you will see in between 3rd to several weeks, and stage 4 where ECG will return to normal. Most important thing is it will not follow the classical phase. Sometime within 1 week it can go from stage 1 to stage 3 to stage 4. This is what you find in most of the things. So, stage 1 is where ST elevation is there, stage 2 it becomes normal, stage 3 it will be flattened T waves, so it becomes inverted, stage 4 it will become normal. What are the commonest causes for pericarditis? Most commonest is viral, Coxsackie virus, occasionally bacterial, fungal and tuberculosis also you see. Immunological conditions like SLE and rheumatic fever, where rheumatic fever it will be pancarditis like pericarditis, myocarditis and endocarditis. Uremia or renal failure, you can also hear a pericardial rub and pericarditis. Post-MI, Dressler syndrome also you will see. Traumatic pericarditis, post-surgery is another cause. Paraneoplastic syndromes, drug-induced, very rarely INH and cyclosporin, and post-radiotherapy. Now, I will show you some of the classical ECGs. This is one example. You can see that there is a ST elevation, especially if you see in V4, V5, V6, you can see the ST elevation, and you can see ST elevation in V4, V5, V6 and in lead 2. And if you see classically in AVR, you can see that ST depression and a PR elevation. This is a classical picture of the what you see in acute pericarditis. This is in stage 1 of acute pericarditis. Another example, here you can see that the mild ST elevation in the lateral leads and in the inferior leads, and typically you see the reciprocal STT changes in AVR and PR segment elevation in the elevation also you see in AVR. This is also in stage 1 of the acute pericarditis. The most important thing is also to see that the patient has significant sinus tachycardia. So, it's the patient has a sinus tachycardia, and that's what you are going to see. Another example, again you can see tachycardia. Here you can see the ST elevation is more pronounced in V4, V5, V6 and V3, and lead 2 you can see significant thing, and you see a significant ST depression in AVR with a PR elevation. This is a classical, again suggesting of PR elevation you can also see in V1. So, this is a typical history of a stage 1 of the acute pericarditis. What is the important differential diagnosis? Important differential diagnosis of pericarditis is early repolarization is one, and myocardial infarction is the other one. So, we are going to spend the next few slides on differential diagnosis of the pericarditis and benign early repolarization, also called ERP, that is early repolarization syndrome. So, the most important thing is to differentiate between these things. So, one of the important clue is what is the ratio of ST and T. So, this is called ST segment and a T wave ratio. The vertical height of ST segment is taken and the height of T wave is taken. So, if the ratio is more than 0.25, it will suggest pericarditis, less than 0.25 suggests early repolarization. So, we will go with some of a few examples. So, here if you see the T wave, it is around 6 millimeters, ST segment is around 1 millimeter. So, the ratio of ST to T is 1 by 6, that is 0.16, it is less than 0.25, consistent with early repolarization. So, here is the example of benign early repolarization. T wave is 6 millimeter, ST is around 1 millimeter, so 1 by 6 is this one. Another example, here the T wave is around 4 millimeter, ST is around 2 millimeter, the ratio is 0.5, it suggests pericarditis. Less than 0.25 suggests early repolarization, more than 0.25 suggests the pericarditis. So another important clue is if you get a fish hook sign, this is early repolarization. Fish hook pattern typically you see in V4, V5. Notched J point elevation in V4 with a fish hook morphology is a characteristic feature of early repolarization. So how do you differentiate ERP and pericarditis? In ERP, ST elevation is limited to precardial leads, whereas in pericarditis it's generalized ST elevation. There is absence of PR depression in early repolarization. Here you find PR depression in pericarditis. Prominent T waves you see in benign early repolarization. Here normal T wave amplitude, and STT ratio less than 0.25 in early repolarization, more than 0.25 in pericarditis. Fish hook appearance is more common in early repolarization, and pericarditis you don't see fish hook pattern. And in pericarditis, ECG will evolve over 1 to 4 weeks, whereas early repolarization it will be there continuously. What it means is, suppose you have an old ECG of 1 year back, early repolarization ECG will look the same, whereas pericarditis ECG will look different. So it's better to have an old ECG to compare early repolarization versus pericarditis. So here, what does the ECG show? Is the tachycardia, heart rate is 95 in a young man. You can see the global ST elevation. You can see in V4, V5, V6, and in 2 and AVF, and also see that there is a widespread PR depression in AVR. You can see that PR elevation and ST depression in AVR, but patient also has a slight fish hook appearance. So here it may be confusing whether it is early repolarization or it's pericarditis, but the ST depression and PR elevation will give a clue that it's a pericarditis. How do you differentiate a pericarditis ECG change versus ST elevation myocardial infarction? So important thing is, again, is there ST depression in lead, AVR and V1? Is there ST depression in lead other than AVR and V1? Then it is STMI. If the ST is convex and horizontal elevation, there is an ST elevation MI. Is the ST elevation greater than lead 3 compared to lead 2, then it's ST elevation. Then you look for PR depression in multiple leads. This will suggest pericarditis if there is a pericardial one. So ST elevation is convex up in ST elevation MI and concave up in pericarditis, and you have to watch for PR segment depression, which will also give a clue. So the other most important thing is, what is the significance of early repolarization? Early repolarization, all of us thought that it's benign, is common in young and healthy individuals less than 50 years of age. You rarely find it above 70 years of age, and it will mimic acute myocardial infarction. 10 to 15% of the people who come to the emergency room, we diagnose myocardial infarction, may actually be early repolarization. Yeah, in many hospitals there are instances where early repolarization has been thrombolized or taken for angiogram, found that everything is normal, there is no myocardial infarction. So it is important to realize that there is a important differential diagnosis, sometimes over diagnosis of and thrombolized patients because of chest pain and ECG evidence of early repolarization, which is over diagnosed. It is less common in above the age of 50 years, and it is important so that we remember the differences between early repolarization and pericarditis and myocardial infarction. How to recognize early repolarization? Is a widespread concave elevation. Predominantly you see in V2 to V5. You don't see in limb leads. J point notching, what you call a fish hook sign. And the most important thing is this is asymmetrical T wave. That is, the ascending limb of the T wave is very slow, gradual, descending limb is very short, pointing, and the other most important thing is ST by T ratio is degree of STT is modest compared to this one, less than 25%, and usually it is around less than 2 millimeter in precardial leads, less than 5 millimeter in limb leads. This is usually the thing. Very rarely you find it more than 5 millimeters. No reciprocal STT changes, and STT changes will be stable over many months and years. So you take a old ECG, it will be still the same. So early repolarization is common between V4 to V6, and it will be 2 millimeter in limb leads, less than 0.5 in chest leads. It will be stable over many years. It will be asymmetrical T, where there is a long ascending limb of T wave with a short descending limb. STT by T ratio will be less than 0.25. So these are some of the clues. And another important clue is the fish hook appearance of the this thing. So here you see that there is a tall T wave, slight ST, concave upwards. In inferior leads it is around less than 0.5 to 1 millimeter. Anterior leads is also around 1 to 2 millimeter, and there is a asymmetrical T wave will be seen. So the STT morphology, you see the T wave is peaked and it's slightly asymmetric. ST segment of the ascending limb is forms a upward concavity, and the descending limb of T is straight and slightly steeper than the ascending limb. So this will give rise to what is typically described as a smiley face. What is a smiley face is what you see. You see that the fish hook appearance, and you see that the long ascending limb which is concave upwards and a shorter descending limb. So this is reference in 2002 by Brady and Morris, who described it as a typical smiley face of the early repolarization, also called benign early repolarization. So here you will make a misdiagnosis of a pericarditis and a ST elevation, this one. So it is asymmetric and it is long concave upstroke. Here you see that the long ascending limb, shorter descending limb, and a fish hook appearance. So here again you see that the typical J point notching, and here you see V4 to V6, typical early repolarization pattern. So another most recent article, what it says is in NEJM, published in a landmark journal in 2009. They say that early repolarization in inferior leads was associated with the increased incidence of death from cardiac causes when you do the long-term follow-up. So sudden cardiac death in early repolarization is one of the hypotheses put forward for idiopathic ventricular fibrillation. So it says that early repolarization may not be as benign as what we thought. So if you follow these people for a long time, they may have increased incidence of sudden cardiac death, especially if you follow for 20 to 30 years. So it's important to realize that early repolarization may not be as benign as we thought about it. So, so this is the coming to our patient, what happened on day 6, he kept on complaining of pain. When we did a echo again, we find that he has a significant pericardial effusion which was not there on day 2. So pericardiocentesis was done. The fluid was suggestive of mostly of viral etiology. Cells were around 200, predominantly lymphocytes. Protein was normal, sugar was normal, viral pericarditis was there. So differential diagnosis, so we thought of any polyserositis. We evaluated ascites, and we didn't find significant ascites or a pleural effusion. And retrospectively going back, patient had a history of cough, cold, fever for 1 to 2 weeks before admission. So it was suggestive of a viral pericarditis. And after the tapping, he was stable. Patient improved with 1 week duration of indomethacin, colchicine, and a short dose of steroids for 1 week. And after that he is being followed for 3 months now. He has no recurrence of pericardial effusion, and symptomatically he is doing well. So in today's case, what we have discussed is a case of acute viral pericarditis. What is important is today differential diagnosis of ST elevation in pericarditis. ST elevation in pericarditis has 4 stages, 1 to 4. Most of the time we diagnose in stage 1, where there is a global ST elevation with ST depression in AVR, and afterwards the ECG normalizes, and then the T wave inversion, then and again it normalizes. That is the 4 stages. Differential diagnosis is early repolarization. Early repolarization most of the time benign, but there are recent reports suggesting that it can be cause for idiopathic ventricular fibrillation. Important thing is to do remember ST by T ratio. If it's less than 0.25, it is early repolarization. More than 0.25 is pericarditis. That is one. The second thing is fish-hook pattern in V4 to V6. Third thing is ECG remains stable for a long time in early repolarization. Fourth thing is less than 0.2 mm in less than 2 mm in lateral leads, less than 0.5 mm in inferior leads, and asymmetric tall concave ascending limb of T with the downward limb shorter. Fish-hook pattern, the concave ascending limb, this is called a smiley face appearance, which we have seen. So that is one. The next differential diagnosis is a myocardial infarction, which is convex upwards, and you don't find a ST depression in AVR, and you don't find PR segment elevation in AVR and V1. So, and that is, and the most important thing is ECG in myocardial infarction keeps varying in hours and days rather than in weeks. So it is important that is a differential diagnosis in emergency room. Overdiagnosis of early repolarization is quite common. That is a few important things. So thank you, and we'll be putting you some questions for this case series. We'll discuss again. Thank you, and we welcome you for the next in the case series. We'll be informing you again. Thank you.